Hello, my name is Allison Dixon, and welcome to my final presentation for the Emergency Ultrasound elective. Today we are going to talk about Beta-hCG and evaluate the discriminatory threshold. Emergency medicine physicians frequently evaluate and manage patients with abdominal pain and/or vaginal bleeding in the first trimester of pregnancy, and the main concern with this group of patients is to identify ectopic pregnancy early. Two of the tools that they use are serum human chorionic gonadotropin, or Beta-hCG, and a transvaginal ultrasound. Before we talk more about Beta-hCG, let's look quickly at what an intrauterine pregnancy looks like at a transvaginal ultrasound. So you're able to visualize an intrauterine pregnancy as early as 5 weeks on a transvaginal ultrasound. You can see here the fundus of the uterus, as well as visualizing the cervix. And for your orientation, on the right side is the anterior and the left side is the posterior aspect of the image. The gestational sac is apparent with a double ring appearance with a darker anechoic center and a brighter circle around it. But a gestational sac alone is not enough to define an intrauterine pregnancy. To define an intrauterine pregnancy, you also need to see a positive Cheerio sign, which is a gestational sac plus a yolk sac. And then visualizing a fetal pole and a heartbeat is just a bonus confirmation of an IUP. Here again at 7 weeks, you can see the gestational sac and the yolk sac and a fetal heartbeat. So what is Beta-hCG and why is it so important? Well, Beta-hCG is a hormone secreted by the placenta that signals to the ovary to continue producing progesterone to support the pregnancy. In normal intrauterine pregnancies, the trophoblastic tissue secretes Beta-hCG in a predictable way, with Beta-hCG levels doubling approximately every 48 hours. So at about 5 weeks, or a Beta-hCG of about 1,500 to 2,000, a gestational sac can be seen on a transvaginal ultrasound. And at 6 weeks, or a Beta-hCG of 5,000 to 6,000, you can see heart motion. Clinically, Beta-hCG is also used in serum pregnancy tests, where a positive test is defined as an hCG level above 5. And since the 1980s, Beta-hCG has had another clinical application called the discriminatory threshold. So what is the discriminatory threshold, otherwise known as the discriminatory zone or level? Historically, it's defined as the level where the sensitivity of the ultrasound approaches 100% for the detection of an intrauterine pregnancy. Basically, when the Beta-hCG is above a certain threshold, and you cannot visualize an intrauterine pregnancy on ultrasound, the diagnosis is ectopic pregnancy until proven otherwise. When Dr. Kadar and colleagues first did their study in the 80s, they found that all normal intrauterine pregnancies in their study were visible on ultrasound when the hCG was 6,500,000 milli-international units or above, and no normal intrauterine pregnancy was visible when the hCG was below 6,000 milli-international units. The scans were all performed transabdominally, which was the standard approach to pelvic sonography at the time. So in the 1980s, the Beta-hCG range of 6,000 to 6,500 was the discriminatory hCG zone, meaning that if the Beta-hCG was above 6,500 and no pregnancy was seen in the uterus, ectopic pregnancy was assumed until proven otherwise. With improved ultrasound technology and transvaginal ultrasounds, more recent zones have been determined between 1,000 to 2,000 Beta-hCG levels. Therefore, women presenting with abdominal pain or vaginal bleeding in early pregnancy with a Beta-hCG above the threshold and no intrauterine pregnancy seen on ultrasound, the presumptive diagnosis is ectopic pregnancy. And so physicians would initiate treatment for ectopic pregnancy without fear of damaging an intrauterine pregnancy. For years, physicians have been debating this discriminatory threshold, and in 2012, the American College of Emergency Physicians came together to write clinical guidelines for patients in early pregnancy, posing two important questions. For pregnant patients who present to the emergency room with abdominal pain and/or vaginal bleeding, and the Beta-hCG comes back below the discriminatory threshold, should you get a pelvic ultrasound? And conversely, for patients with an indeterminate transvaginal ultrasound, how useful is Beta-hCG in predicting possible ectopic pregnancy? Well, it is well documented now that ectopic pregnancies can present at almost any beta-hCG level, high or low, and some clinicians may defer an ultrasound when the beta-hCG level is below the discriminatory threshold because they think that the risk of rupture is low. However, rupture of ectopic pregnancies can occur at very low beta-hCG levels. Other providers may delay pelvic ultrasound because they think that the diagnostic utility of ultrasound is low when beta-hCG is low. However, studies have shown that at least a moderate sensitivity, 40 to 60%, for diagnosing intrauterine pregnancy or ectopics with beta-hCG levels below 1500. And some smaller studies have shown even higher sensitivity of transvaginal ultrasound identifying ectopic pregnancy. So essentially, for the first question, the emergency physicians have recommended at the level C recommendation to perform or obtain a pelvic ultrasound for symptomatic pregnant patients with a beta-hCG level below any discriminatory threshold. Now for the second question, in patients who have had an indeterminate transvaginal ultrasound, what is the diagnostic utility of beta-hCG for predicting possible ectopic pregnancy? Now most patients who receive an ultrasound in the emergency room as part of the workup receive the diagnosis of viable intrauterine pregnancy or an abnormal pregnancy, like ectopic pregnancy, fetal demise, or molar pregnancy. But about 30% of patients receive the result of indeterminate ultrasound, which makes management much more difficult. Almost all studies looking at patients with indeterminate ultrasounds found that the beta-hCG levels could not be used to predict final diagnoses, with only one study showing a strongly predictive likelihood of ectopic pregnancy based on the beta-hCG. Dr. Connolly's group recently reevaluated the discriminatory thresholds through a retrospective cohort study and developed these models here to show the level of beta-hCG correlating with visualization of the gestational sac, yolk sac, and fetal pole on ultrasound. The beta-hCG level associated with 99% probability of detection of a gestational sac was 3,500 milli-international units per mil, which is higher than the current discriminatory threshold. This suggests that using the beta-hCG level of 1,500 milli-international units as a discriminatory value for patients, they would have detected only 80% of the ultimately viable pregnancies and led to 20% mismanagement rates of viable pregnancies, which is a gross underdiagnosis of viable pregnancies. This misdiagnosis and mismanagement has been the main concern and cause of many malpractice suits. And treating an intrauterine pregnancy that was thought to be ectopic with methotrexate has led to the failure of the pregnancy or miscarriage or the birth of a malformed baby. Basically, the discriminatory threshold is not as reliable as previously thought, and the idea of using beta-hCG as a screening measure for ectopic pregnancy may need to be thrown out the window. New guidelines published in the New England Journal of Medicine in October of 2013 have changed the criteria in order to reduce the risk of prematurely stating a pregnancy is non-viable. As part of these guidelines, findings diagnostic of pregnancy failure include a crown rump length of greater than or equal 7 millimeters and no heartbeat, a mean sac diameter of greater than or equal to 25 millimeters and no embryo, the absence of an embryo with a heartbeat greater than or equal to 2 weeks after a scan that showed a gestational sac, and the absence of an embryo with a heartbeat greater than or equal to 11 days after a scan that showed a gestational sac with a yolk sac. So in summary, again, the findings diagnostic of pregnancy failure include a crown rump length of greater than or equal to 7 millimeters and no heartbeat, the mean sac diameter of greater than 25 millimeters and no embryo, the absence of an embryo with heartbeat greater than or equal to 2 weeks after a scan that showed a gestational sac without a yolk sac, and the absence of an embryo with heartbeat greater than or equal to 11 days after a scan that showed a gestational sac with a yolk sac. And these are a list of findings that are suspicious for pregnancy failure, but again are not diagnostic of pregnancy failure. So having a smaller crown rump length with no heartbeat, a mean sac diameter of 16 to 24 millimeters and no embryo, the absence of an embryo with a heartbeat 7 to 13 days after a scan that showed a gestational sac without a yolk sac, the absence of an embryo with a heartbeat 7 to 10 days after a scan that showed a gestational sac with a yolk sac, and the absence of an embryo greater than or equal to 6 weeks after the last menstrual period, and empty amnion, which is an amnion seen adjacent to a yolk sac with no visible embryo. Some final points here. A single measurement of beta-hCG does not reliably distinguish an ectopic versus intrauterine pregnancy. While serial beta-hCG levels may provide some more information, a single measurement should not be used as a screening measure to rule out ectopic pregnancy. Additionally, providers should consider pelvic ultrasounds for symptomatic pregnant patients below any beta-hCG discriminatory threshold. And again, we cannot use beta-hCG to exclude the diagnosis of ectopic in patients who have an indeterminate ultrasound. And it's advisable to obtain a specialty consult from OBGYN or arrange close outpatient follow-up for all patients with an indeterminate pelvic ultrasound. Thank you so much, and that concludes my presentation.